Kickstarting session 6, titled Diagnosis, Genotypic and Clinical Features of CCDS Patients. I'd like to invite Dr. Kim Cecil. So Kim joins us from Cincinnati Children's Hospital Medical Center. Kim will be presenting today on females with CTD syndrome.
Is this on? There we go. Thank you so much for the invitation to share my work. This is actually work done with Catherine Morey. Okay, thank you. Who is a summer student in my lab, and Dr. Barbara Hallinan, who's a neurologist at Cincinnati Children's. We published this report in Radiology Case Reports this year in February. If you want to read some more details, we have no financial disclosures. So, proton MR spectroscopy, you've heard a lot about it, so let me try to dissect it so everyone sort of has a baseline understanding. This is a specialized test that is performed during an MRI examination. You have to have your physician order this test. It will not be done automatically. And the way it's done in most institutions is a technique called single voxel, where the radiologist and their spectroscopist, imaging scientists working in the lab, you have to prescribe specific locations. The good news about creatine deficiency syndromes, if there's any good news, is that wherever they sample in the brain, if creatine is deficient in males, the worst radiologist in the world can still diagnose this disorder because that creatine peak is dramatically declined. And let me try to point here. So let me go through here. I'm sorry, I'm not getting this to work. So, okay, thank you. Thank you so much. So N-acetylaspartate is our largest chemical. You also see glutamate with spectroscopy, creatine and phosphocreatine on a proton MR spectroscopy that's done with an MRI scanner will be present here at 3 parts per million, but also underneath this peak is GABA and glutathione. So that some of the confusion in research is there residual creatine there, or is that GABA and glutathione? We also get a cellular membrane marker, and we get a glial cell marker. In this illustration, I'm sampling in the frontal lobe and the anterior cingulate. So this is an example of a patient. This is actually the index patient. Dr. DeGraw had originally referred to, since the radiology department, a child with unexplained delays, and his head was getting too large. So we had set up a program that where you sample in the brain, based on that history, we would place the voxel in those locations. So the enlarged head set a signal to us that white matter should be affected. The unexplained delay in a child under 12, the basal ganglia region of the brain should be affected. And that's where we were able to note the first deficiency of the creatine. And with the work of Dr. Solomon's, we were able to sort out that this was not a synthesis defect. Another thing, yesterday we had to just talk with Terry mentioning luck. I would say it's providence, because the creatine transporter deficiency, creatine transporter gene had been mapped in 1994 and published. And I came to Cincinnati Children's in '98, set up the spectroscopy program. In 1999 was when the first patient was identified. So all this stuff was coming together to get this discovery. The spectra for this patient, again, now he's 15 years old in this particular image. His brain is basically normal, but on these 2 different spectra where I have the red arrow, you see the area under the curve that is a representation of GABA, glutathione, and potentially creatine. So at 3 parts per million, it's pretty stable from when he was 6 when we did our initial evaluation, and now at age 15 for this examination. So spectroscopy was important in CT at Cincinnati Children's for a long time because historically 7 of our 9 families had their affected son identified through the course of just a clinical workup, getting the MRI to try to understand their delay. And it was used to be a functional test. Once the gene was identified, was that pathogenic? Now I want to talk to you about our young lady that has come across through our service. She was born with cesarean section, no family history of neurodevelopmental disorders. She's had seizures. She had verbal and nonverbal communication deficits. She was diagnosed at age 4 with autism, as a IQ around 59. She had mixed receptive expressive language disorder, no sentences, just single words. She had self-injurious behaviors, repetitive behaviors. She's had seizures. Fortunately for her, by age 7, the seizures had stopped. She had some difficulties in caring for herself. She had obesity on top of it. She had sleep apnea that did improve with tonsillectomy and adenectomy. The geneticist had performed microarray test and Fragile X screening panels. Both were normal, but the important thing for her was getting this autism intellectual disability expanded panel that revealed a de novo pathogenic mutation. Again, her brain imaging at age 6 was normal, but age 8, the physicians ordered spectroscopy, and it confirmed that it was a functional test. Now, this is where I told you before, for males, you could have the worst radiologist in the world. You need the top 40% for females with CTD. And the reason why I say this is you look at the spectra and you say, hey, there's creatine there, it should be fine. But in that top corner, there's some little numbers, and each MRI vendor, regardless whatever scanning facility you go to, they get this semi-quantitative ratio. So it's the ratio of NAA to creatine, choline to creatine, and most of the time, creatine is either creatine or phosphocreatine. So the creatine is kind of the internal reference for a spectra. So most radiologists are familiar with the levels of that ratio of NAA to creatine, choline to creatine. And what goes weird in females is that ratio becomes way too high because creatine is actually lower, though visually it doesn't appear to be bad. That is a short echo technique. This is a long echo technique, and if the site chooses to do long echo, they may notice that creatine is diminished in this one more so than the short echo. And there's different reasons for different conditions why we do these two different contrasts with spectroscopy. So what I did was I extracted the raw data from our scanner and was able to do proper quantification. And when I did this and compared it to typically developing children at our facility, the creatine is actually 40% lower. So from my experiences and working with Dr. DeGraw when we evaluated some of the first families with CTD, we scanned their mothers, their aunts, their grandmas, their sisters. We found somewhere between 40 and 60% of normal creatine levels in the brains of the females. So diagnosing female CTD is very difficult. A lot of great work done in Europe, in France, and in the Netherlands, that urine creatine to creatinine levels are not specific. So urine screening is not useful for female CTD. Again, the spectroscopy has to be done with rigorous quantification to really get at that 40% roughly decline. So for females, the exome sequencing is the best option. The challenge is getting that daughter to get that test. And hopefully now that some of these tests are lower in cost, there's more availability, more recognition, these patients can be identified earlier. And before I end on kind of a little negative note, I reached out to Dr. Hallinan last week to check in on our young lady. She was seen last fall. She's 12 years old. Dr. Hallinan had shared that she knows the days of the week. She can say them forward and backwards. She knows the months and the year. She said it was an overcast day with clouds, and they'd look out the window, and she would ask the patient, what do you see in the sky? And what does that mean? And some questions like that. And she knew it was going to be a rainy day. And she was actually smiling and happy and giggling. And thanks to the work of this patient's mother and her teachers and getting the resources, she was really able to overcome some of these self-injuring behaviors, and just setting up some safeguards and boundaries to try to teach her daughter, to not harm her brother and hit her brother and things like that as I was doing the case review. So there is hope. So thank you very much.
Dr. Cecil, thank you for that informative talk. Next, I'd like to invite Denise K. Denise joins us from the newborn screening program at the Wadsworth Center at New York's State Department of Health. So as you heard yesterday and earlier today, GAMT newborn screening has been pursued in Utah and New York was one of the states that did identify an individual through newborn screening. Denise, we're so grateful for your work and looking forward to hearing from you about the first 3 years.
Thank you. Thanks for your attention and thanks for the invite to be here. So I'm going to talk about implementation of universal GAMT screening in New York State. So in New York State, we have a central lab. We screen all babies born in the state for more than 50 different conditions, and we do that using dried blood spot specimens that are collected at the hospital of birth before discharge. In 2021, we had more than 211,000 births in our state, and this represents about 6% of all births in the US. We are a very high throughput lab. We test about 1,000 specimens a day, where our goal is to rapidly identify, refer babies for diagnosis, and treat before symptom onset. So GAMT deficiency is a treatable condition resulting from a defect in a well-characterized biochemical pathway. There's clinical benefit in early identification, and so that to us says this could be a good condition for newborn screening. And so there's been quite a bit of work done actually on this, as Dr. Pasquale alluded to earlier. So newborn screening for GAMT deficiency was actually started in Australia about 20 years ago, and it's actually gotten very little attention. So they started screening in 2002, performing universal screening on all babies. They did publish a commentary in 2013, and they had screened about 770,000 babies, but not detected a real case. Rumor is that as of very recently in 2022, after screening 1.3 to 1.4 million babies, they have detected a case, but the last that I heard, the diagnostic testing hadn't been completed, but it was highly suspicious to be a confirmed case. Utah, where we are, validated a 2-tier method for screening dried blood spots for GAMT deficiency. So the first tier is a screen for guanidinoacetate and creatine using mass spectrometry. Second tier analysis is done using an HPLC method, so high performance liquid chromatography. And this is used to separate the guanidinoacetate from an unknown isobaric interferon, and it reduces the rate of false positive results from the first tier. So you're basically isolating only the guanidinoacetate when you're using the HPLC. So they did a retrospective analysis at that time, and they de-identified archived newborn screening dried blood spots. They tested 10,000 specimens and found no cases. British Columbia also developed a method very similar to the Utah method, except that they also included a third tier where they sequenced the GAMT gene in positives. And so they performed a prospective analysis, so testing specimens in real time as they came to the program, and they did this over a 3-year period. They still did it in a de-identified fashion. I think they had tested 135,000 specimens, also didn't detect a real case. And I also did hear recently that I think they're still doing this, actually. I think they did implement GAMT screening. And then finally, what I'll focus on today is implementation of screening in New York. And so we got together with the Utah Newborn Screening Program and published results of the first couple of years of screening by both of our programs. Utah was actually the first state in the United States to implement screening for GAMT, and they did that in June of 2015. So let me mention that GAMT was nominated to the RUSP. The RUSP is the Recommended Uniform Screening Panel, and this is a panel of conditions that are recommended to be suitable for newborn screening by the Advisory Committee for Heritable Disorders in Newborns and Children. And so that committee is tasked with evaluating and either recommending or not recommending that a particular condition should be added to this recommended panel. And so GAMT had been nominated for addition to the RUSP, and there was a work group that was assigned to review the evidence, and they noted that GAMT was a medically important disorder, had a well-established case definition, a non-invasive treatment. There'd been a newborn screening test that had been developed. However, they said that because an affected infant had not yet been identified by prospective newborn screening, that it just wasn't ready. So they did not add GAMT to the panel, and they did say that once infants with GAMT deficiency had been identified by pilot studies, that it could be reconsidered. And so the RUSP is a recommendation. It's not a requirement. Individual states determine what conditions that they screen for. Individual countries do the same. And so in New York State, we generally align with the RUSP, but we are not mandated to follow the RUSP strictly. Some states do follow it exactly. And so with few exceptions, we screen for all the conditions on the RUSP, and then we have a couple of extras, and GAMT is one of those. So we can our health commissioner can add conditions to the panel. The commissioner can authorize that. And so we had seen these other tests that had been developed by Utah, British Columbia. We had a parent advocate in our state who had approached our program director. And so we started developing a method in our own hands, working on the test. And our leadership agreed that we were ready to start testing. And so we implemented universal screening in October of 2018. So I don't think I need to remind you all, but just quickly, GAMT deficiency is due to mutation in the GAMT gene. This results in elevated guanidinoacetate, sometimes abbreviated GUAC or GUAC or GAA, and also depletion of creatine. And so in newborn screening, we are looking for both elevated guanidinoacetate and low creatine. This is what our current newborn screening algorithm looks like, and it's based heavily on what Utah and British Columbia did. So we have a first-tier screen for guanidinoacetate and creatine. We do this by taking our dried blood spot specimens, extracting the analytes, and analyzing them using flow injection analysis, mass spec, and this is kind of the workhorse of newborn screening programs. We test most of our conditions using this platform. And so babies with low guanidinoacetate or low creatine are released as screen negative, which you can see in the lower left-hand corner. We do assess our creatine not as a value, but as a ratio, so it's analyzed in the context of guanidinoacetate levels. Babies who have borderline guanidinoacetate and low creatine, they are considered, so borderlines instead of referring them for a diagnosis, we request a repeat heel stick from those babies because they're only slightly abnormal. And most of those resolve when we have a retest in-house. And they're tested on a repeat heel stick. And then babies who have significantly elevated guanidinoacetate and a high ratio of guanidinoacetate to creatine are considered screen positive. We do sequence the GAMT gene in all of our screen positives, but I'll emphasize that we do this to provide additional information to our clinicians. If you have a baby who has abnormal biochemical levels and 2 pathogenic mutations, you can be pretty sure that the baby is affected, but we don't use the molecular results to make decisions, and we don't say a baby is negative or positive based on the sequencing. So I will mention, I don't have time to go into all the details, but this is a modified method. We started out using an algorithm that was more similar to the Utah and British Columbia, where there's an HPLC. That was smart to try to do it on there. So there's a second tier assay that we used to run using the high performance liquid chromatography. And one of the chemists in our lab was able to determine that the HPLC actually isn't necessary if you just analyze your data in a different way off of your mass spec. So we use an alternate product ion, and we've effectively eliminated the need for the HPLC test, so saving time, money. And the reason I bring this up is because I'm going to show you our data in the context of both algorithms. So for the first 1.5 years of screening, we tested 317,000 babies. 4,100 were reflexed to that second tier analysis. 319 had borderline guanidinoacetate levels, and we requested a repeat, and 17 were sequenced and referred. And now if we look at our modified algorithms, so in the second column, this is using that alternate product ion, so the different analysis for the mass spec, alongside the HPLC. So we ran both the alternate ion and the HPLC for a little while just to be sure we weren't going to miss anything. And what you can see is we went from needing to test 4,100 babies on that HPLC down to 110. And the number of babies that we tested was about 315,000 for both. So that modified product ion significantly improved our test. In the third, we also, so during the initial period, we had 319 borderlines, 17 referrals. With the modified algorithm, we got down to 77 borderline and 7 referrals. And so this third column shows the period when we were confident that we could eliminate the HPLC test. And so you see no more babies are being tested on that second tier. We had 31 borderlines and no referrals. So this is a significantly better test for us. Overall, we've tested 783,000 babies from October 1, 2018 through May of 2022, and we've only referred 24 babies. And so we're considered a screening lab. We don't diagnose, we screen, and we refer for a clinical diagnosis. Among those 24 babies, 15 were confirmed to have no GAMT disease, so false positives, and we had 1 confirmed GAMT deficiency. So this shows the timeline for this baby from birth to referral to treatment and testing. So basically we received her specimen on day 5 of life. We tested using the first tier mass spec assay and found elevated guanidinoacetate, way higher than our reference range, low creatine. Same thing on the HPLC test, very high guanidinoacetate. We sequenced her GAMT gene and found 2 pathogenic variants, so we were pretty confident that this case would confirm. She was referred on day of life 8, so this is very quick. And this happened during the pandemic, so she was seen by telehealth on day of life 11 and treated by day of life 17. On day of life 19, diagnostic testing, I believe at ARUP, confirms the diagnosis of GAMT deficiency. And so The last update that we have is that the baby was on treatment, doing well, creatine, ornithine, and benzoate supplementation with also protein-free formula. And this is another benefit of newborn screening. So she had an older sibling that was 6 years old. This child had developmental delay, no speech, hypotonia. She had a normal MRI. She'd been evaluated by genetics and neurology, but she had no diagnosis. So as soon as we referred this baby, the physician said, aha. And so we tested her dried blood spot specimen, and also she was tested at the diagnostic testing lab, and GAMT was confirmed. So treatment was initiated for this child as well, and she had been reported to show improvements. So in conclusion, we have been able to incorporate the GAMT method just into our existing method for analysis of amino acids and acylcarnitines. We didn't need new equipment, we didn't need new staff. It's a relatively easy test to implement. A second-tier assay reduced the false positives, but we didn't really need it. And so our borderline rate is 1 in about 4,200, or 1 a week. And our referral rate is also very low at 1 in 67,000 babies, so 3 to 4 a year. This really is one of our better tests. On the other hand, the incidence is low, so we detected 1 case out of 785,000 babies screened, but the estimate is not precise because this is a really rare condition. And so just to end, I should mention that before we identified our affected baby, Utah affected a baby by universal screening about a couple of months before we did. And so these 2 cases were brought back to the Secretary's Advisory Committee. GAMT was renominated. In 2021, it moved to an official evidence review. In 2022, just in May last month, it was recommended for addition to the RUSP. Just needs signature by the Secretary, and then states will likely begin screening. So thank you very much to the association, and this is a whole team that did most of this work, so thank you very much.
Thank you so much, Dr. K. I have to say that this symposium has been illuminating in breaking down several aspects of newborn screening and the methodologies associated with it. It's a complex process, and while GAMT and CCDS and other CCDS are rare, what a difference that diagnosis makes for that family and for those kids. 1 in 785,000 patients, but their life is just clearer for having that diagnosis early, and they can move on to thinking about therapies and improvements to daily life. So thank you so much for all the work that you do. Welcoming our next speaker, Dr. Jenny Goldstein. I'm sure some of you had the opportunity to interact with Dr. Goldstein also yesterday while she moderated one of our panels. A brief introduction to Dr. Goldstein. Her interest in CCDS began in 2004 when she was at the biochemical genetics lab at Duke University. She was involved in one of the foremost studies to develop and measure the level of guanidinoacetate in newborn blood spots. Subsequently, she began working as a senior biocurator for the Clinical Genome Resource Center at the University of North Carolina. And she continues to work with them as well as us in the capacity of the Clingen CCDS VCEP, or the Variant Curation Expert Panel.
Thank you so much for the introduction. And thanks for the opportunity to talk about the work of our group. And I will point out this is a group effort. Our co-chair of this group is Dr. Sadet Andrews, who is here today, also Dr. Sarah Young and Dr. Nicola Longo, who was here yesterday, and Heidi Wallace also. It really is a group effort. So today I'm going to give you a brief introduction to the Clinical Genome Resource, or ClinGen, and then talk in a bit more detail about our Creatine Deficiency Syndromes expert panel. So I wanted to start out just by describing a challenge in clinical genetics. So we now have powerful DNA sequencing technologies where we can sequence a whole genome, a whole exome, we can sequence hundreds of genes that are involved in a particular clinical indication, like developmental delay or seizures. And from those genetic tests, we may identify a number of genetic variants. But the question is, what do those genetic variants mean? Which of those genetic variants or mutations are causing disease, and which may simply be benign and not having any clinical effect? So this process of variant classification, or trying to determine which variants are causing disease, was the motivation for starting the Clinical Genome Resource, or ClinGen. So the mission of ClinGen is to create a publicly available resource that defines the clinical relevance of genes and variants. So this effort was initiated in September 2013, and it's funded by the National Human Genome Research Institute. And since it started, this effort has really grown tremendously. We now have over 1,800 investigators across 45 different countries. So ClinGen is really a curation effort. So what that means is we're collecting data from different sources. So for example, published research articles in scientific journals, also data from labs, public databases, and so on. But one of our core curation activities is variant pathogenicity, or again, determining which variants in a particular gene are causing disease. And in order to do this, ClinGen encourages sharing of genetic and phenotype data. So again, hoping that people will publish their results in scientific journals. Also, clinical labs, they have a huge amount of data, so it can be really helpful when they share that data. And also registries, like the registry that the ACD is running as well. ClinGen has also established informatics infrastructure in order to meet these goals. We've developed standardized evidence-based evaluation frameworks for these purposes. And our goal is also to engage the international community of experts to help with this effort. There we go. ClinGen's variant classification process is based on guidance that was published in 2015 by the American College of Medical Genetics and Genomics and the Association for Molecular Pathology. So this guidance is now affectionately known as the ACMG criteria. And what it did was to outline different types of data that can be used when you're trying to evaluate whether a particular variant is causing disease or not. And this includes data like population data. So do we see a genetic variant in the general population? And if so, how frequent is that variant? Also looking at computational algorithms that can help determine whether a genetic variant is affecting the function of the protein or not. And also functional data, like some of the assays we heard about yesterday for SLC6A8. So there's a set of pathogenic criteria, which can be met at different levels of strength. You can see here on this slide that strength can go from supporting, moderate, strong to very strong. And that really just depends on the strength of evidence that is available. And then a set of benign criteria as well. So we go through all of the data, we see which of those criteria a variant meets, how many of the criteria are met, and at what strength. And all of that data together will end up with a final classification of either pathogenic, meaning we have high confidence that that variant is causing disease, likely pathogenic, a variant of uncertain significance, which we don't know either way, or likely benign or benign, meaning that that variant has no clinical impact. So classifying variants in this way is actually really important. So for one reason, if we see this variant again, we can be much more confident about its impact on clinical features. Classifying variants can also be really helpful for familial testing. So if someone else in the family wants to be tested, it's good to know exactly what the clinical impact of that variant is. It can also help with resolving if there's biochemical ambiguities with the results. The genetic testing can certainly be a part of the diagnostic process. And then also helping with newborn screening as well. So while the ACMG criteria have been really incredibly helpful with variant interpretation, variant classification, they really are very general. They were written to really cover a wide range of different Mendelian disorders. So that can make it a little bit difficult sometimes for an analyst in the lab to know what kind of data can I use, what strength should I apply this criterion, and so on. So ClinGen is tackling this problem by assembling variant curation expert panels. So these are groups of individuals with expertise in specific genes and diseases. And I'm showing on the bottom of this slide the process that ClinGen has developed for these expert panels. So once the group has formed, they will go through each of the different ACMG criteria, decide which criteria are applicable to a gene, and if so, are there additional specifications that we can add. So one example might be, for example, functional data. What is a good functional assay for a particular gene, and what sort of recommendations would we use for applying that data in the variant classification process? Once we've gone through all of the different criteria, there's then a pilot stage where the group will look at about 30 to 50 variants and try out their criteria just to make sure everything is working as expected. And then all of this process is overseen by ClinGen, so there's a final approval step before we can then publish our classifications to public databases, including ClinGen's evidence repository and ClinVar. So for those of you who are not familiar with ClinVar, this is a public database that aggregates variant classifications from submitters worldwide. This includes clinical laboratories, researchers, clinicians, and it now has close to 2 million submissions. So if you're interested in a particular variant, you can go to ClinVar, look it up, see if someone has submitted data on that variant, and see what they've said about it. So it's actually a really powerful resource. And I also want to mention that ClinGen's variant curation process was actually the first to be recognized by the FDA as a public human genetic variant database back in 2018. So when a ClinGen expert panel submits their data to ClinVar, we get this nice little FDA-recognized database tag that shows that it's coming from an expert panel and it is an FDA-recognized process. So with that being said, and the reason we're here is that we have been working on a creatine deficiencies variant curation expert panel. We currently have 12 active members from the USA and Canada, and we have specified the ACMG AMP criteria for the 3 CCDS genes. We've completed our pilot study, so we've looked at 30 variants across the genes, so at 90 in total. And we're awaiting our final ClinGen approval before we can submit those pilot classifications to ClinVar and then continue with our variant classification process. So this is a summary of our pathogenic criteria. I'm not going to go through all of these in detail, but there were a couple that I wanted to focus on a little bit today. So the first of those is the PP4 code, which basically asks the question whether a patient in whom you see this variant, is their phenotype or family history highly specific for this disease? So when you think about the creatine deficiency syndromes and the symptoms that we see, those symptoms are not necessarily highly specific. When you think about things like developmental delay and seizures, those features can be seen in many different genetic conditions. What is specific and very highly specific for these disorders is the biochemical features. So looking at levels of guanidinoacetate or creatine in different sample types, and then also the MRS data as well. So what we did for each of the 3 genes, after a lot of discussion, was to set up a point system that would allow us to assign a specific strength of evidence for this particular criterion, depending on the amount of evidence that is available for that particular patient. So the more evidence that we have, the higher strength of evidence we can apply for this code, and that really helps with the variant classification. So thinking about the registry again, any of you involved in the registry, it's really, really helpful for us to have this particular biochemical data, especially pre-treatment, because it can really help with this variant classification process. A second code I wanted to mention is PM3. So this is a code that is used for recessive disorders like AGAT and GAMT deficiency. So for individuals with these conditions, because they are recessive disorders, you would expect to have a variant on each copy of the gene. So for this code, if you're looking to classify one of those variants, you look at what's on the other copy. That variant could be identical if it's a homozygous case, or that variant could be different. So if the second variant is already a known pathogenic or likely pathogenic variant, we can assign a certain weight of points in that situation. But we can also assign more evidence if we know that one of those variants came from mom and one from dad. So again, really helpful to have the results of parental testing for this particular code. And then we simply add up all of our points, as shown on this slide here, to assign our final weight of evidence. I should also note that parental testing results are also helpful for the X-linked disorder, the SLC6A8, in order to show whether that particular variant is occurring de novo or not, because that's a mechanism of disease for that condition. So, and that allows us to apply the de novo codes for variant classification as well. So just moving on to our benign criteria, I'm just going to focus on one of these, that's the BA1 criterion. And this is what's known as a standalone criterion. So if a variant meets this particular criterion, we know for certain that it's benign, it's not causing disease. And what this criterion is asking is this variant too common in the population to be causing disease? So we can look in population databases, we can determine how common that variant is, and if it meets a certain threshold, we can apply this particular code. So we have determined the different thresholds for each of the 3 genes for BA1. So now I'm just going to show you a couple of examples of how this all works. So this is a screenshot of our Clingen variant curation interface showing data that was entered for one of the SLC6A8 variants. This is a deletion of a single amino acid in the protein sequence. And you'll see the colored squares are showing the criteria that were met for this variant. So the first of these is PP1, which is a code that describes segregation of the variant within a family. So can we track the variant with the disorder in a family? And based on the data that we found in the literature, we could apply this code at the moderate level. PP4, I've already talked about, so there are actually several patients in the literature that met this code at strong. These patients had highly elevated urine creatine and also MRS data showing absent creatine. PM2 is a population data code, and so if we look in our large population database called NOMAD, we find that this variant is absent, so we could apply that code. It's rare or not seen in the general population. And then PM4 is a code that can be applied because this is what we call an in-frame deletion, so it's just removing a single amino acid. And then lastly, PS4 is a code that describes that there are more affected individuals with this variant than unaffected. So we see at least 3 additional unrelated affected individuals in the literature. So all of this comes together to give us a pathogenic classification for this variant. A second quick example is for GAMT. This is a variant that is not actually affecting the amino acid sequence. And this variant met our BA1 threshold, so we would classify this variant as benign. But just to check, we looked at a couple of other codes as well. Sometimes when you see a nucleotide sequence like this, it can affect a process called splicing, and there are a couple of codes that look at that, and those were also benign. So this is definitely a benign variant. So just to summarize our work so far, as I mentioned, we've looked at 90 variants across these 3 different genes. I'm showing here a graph that's showing the number of variants we've classified of different variant types. And you'll see in gray, this shows what we call variants of uncertain significance. So again, these are variants that we don't know for sure whether or not they are causing disease. And you'll see that the majority of these are in the missense category. This is where one amino acid is changed to another. And missense variants can be notoriously difficult to classify for various reasons. So hopefully over time, with more data, we will be able to resolve these and determine whether or not they are pathogenic. And in fact, when we look at the ClinVar classifications of the variants in the CCDS genes, so this is coming from all of the submitters who have submitted data on these genes to ClinVar. You'll see it's also an issue for other labs as well. So again, in gray, showing the variants of uncertain significance. And then those smaller sections in green are where 2 submitters don't agree with each other. So one lab may say a variant is pathogenic, another may say it's a variant of uncertain significance. So these are things that our expert panel definitely wants to try and resolve over time. So that brings us to our future directions. Certainly resolving these variants of uncertain significance and conflicting classifications is going to be really important. And in that respect, more data definitely helps. So the more data that we can get from patients, families, and also the functional data that was talked about yesterday. And so in that respect, we are partnering with the Association for Creatine Deficiencies in terms of obtaining data from the registry. So I just want to say thank you so much to everyone who is participating in that. And again, biochemical data is really helpful, and also the results of parental testing as well. We also plan to submit our pilot and future variant classifications to ClinVar and the Clingen evidence repository once we get our full approval from Clingen. And then we're planning to publish a manuscript on our variant classification specifications as well, because then that's important that other labs and so on can use these specifications. So finally, just a huge thank you to everybody who's been involved in this project. Again, I know there are several members of our expert panel here in the audience today. A huge thank you to Dr. Sedette Andrews, Dr. Young, Dr. Longo, and Heidi Wallace. Yesterday, Amanda Thomas was here also, and also Kim Hart. But thank you to everyone on this list. Thanks also to my colleagues at UNC and at Clingen, and to the Association for Creatine Deficiencies.
Thank you so much, Dr. Goldstein. Can I invite all the session speakers up to the podium, please? Also, Dr. Sarah Young, who will be moderating this session. So Dr. Young is a clinical biochemical geneticist and a director of the Duke Biochemical Genetics Lab. She's involved in the development of mass spec and analytical tools, as well as in the discovery of biomarkers for different rare genetic disorders. So very appropriate panel over here. I'm looking forward to the discussion. As a reminder, the Q&A will run till 11:15, at which time we will start the next session. Dr. Young, would it be all right if I started with one question for Dr. Cecil?
Very, very much all right.
This is from one of our virtual speakers in the previous session. In the published paper where the case that you talked about was presented, you found that creatine treatment worsened behavior. Do you have a theory about this?
Not being the clinician on this, as the imaging scientist, a little hard trying to recall. I am coming across some of the age issues. So in thinking about this patient, as we reviewed her record, there were certain periods where, whether it's the family circumstances, she has an older brother, and throughout there she was always, striking and hitting the brother, and the family was working to try to figure out what conditions triggered this aggressive behavior. And then I fly back tomorrow. On Wednesday we have another female, same sort of situation. The genetic testing has found her, and they're using spectroscopy. And in part of our conversations, the reason that they want spectroscopy done in a certain way so we can evaluate treatment a year from now. And we were having the discussion of, could this enhance aggressive behaviors? The child's is 17 years old. Does it strengthen the muscles? Is it affecting the brain in a way that causes this aggression? I don't think we fully understand that, but what was hopeful from these conversations was that with certain behavioral modifications, setting boundaries for the child, it could alleviate some of them. It's just, we just don't know enough yet. I'm sorry.
Thank you.
So I would like to thank all the speakers. They were excellent talks on a very important topic. We all in this room are too familiar with the diagnostic delays for this group of disorders and the impact that has on families from a psychological and treatment point of view. We heard from Dr. Cecil about the importance of the spectroscopy, especially for the females, for which it's very difficult to receive a diagnosis. As we heard from Jenny, the molecular results from a exome or a genome screen may not be definitive. You may end up with variants of unknown significance. So having functional data like spectroscopy is very important. Then we heard about the biochemical applications in the newborn screening lab and how important they are in picking up pre-symptomatic patients with GAMT deficiency, and what a great step forward for this population this is going to be. It's a major achievement. And then finally, the importance of accurate curation of variants and how this will impact us. So I would like to start off with just the question for each of the speakers. I'll try and be as quick as possible. For Kim, I would like to ask what efforts have been made to improve the education for those 60% of spectroscopists who need more help?
We do a lot of, it's lacking is the thing. We try to do publications, but there's so many rare diseases and neuroradiologists become intimidated by it. They have one colleague in their group that gets the neuro, the weird, the unusual, the typicals. Cincinnati's near Lexington, Kentucky, so we talk about horses. They're used to looking at horses, so when a zebra comes in, they don't recognize it. They think, okay, it's got a mane, it's got a tail, it's got 4 legs. And we try to write as many articles, we try to educate in the neuroradiology sessions, but it's kind of this intimidation that there's all these atypical metabolic diseases and there's no way I can remember them. But we also heard yesterday the Google machine. So, putting something in, so many times a neuroradiologist will say, I found your disorder by Googling because I saw this unusual spectrum. In males, especially, the spectra is so atypical, it raises the red flags so they can figure this one out. The females, it's just harder. You have to be more rigorous.
Thank you. And for Denise, I would like to ask, a lot of the screen positives are borderline, and when they are repeated on a new spot, they come back as negative. So that, presumably those repeat spots are collected on older infants. Do you have a different cutoff for that different age group?
So we actually don't, and there's another bit of interesting data that we have I didn't have time to show. So of those babies with borderline guanidinoacetate levels, 97% of them were in the NICU. So what's going on is that there's some interferent that is, we think, some treatment that babies in the NICU are receiving, and that causes them to have falsely elevated guanidinoacetate. And you also see that effect in babies who are referred, but it's less pronounced. It's like 70%. So the cutoffs are the same, to answer your question directly. The cutoffs are the same for the initial and the repeat specimens. But there's something going on, and that's been seen and has been reported before in the literature. That's nothing new.
And my question for Jenny is about the number of variants seen in the different genes, especially for CTD. Could you speak to that and how that impacts, individual diagnoses?
Yeah, so if we look in the ClinVar database, I think there were about 600 SLC6A8 variants, and that runs across the spectrum from benign through pathogenic, and about 400, I think, for GAMT. One of the issues with the variant classification is that many of these variants are found only in one family, one or two families, so it can be harder to classify because there's just less data. There are a few more common variants that are pretty well understood, so we know when we see those that they are definitely pathogenic and they're better characterized in terms of function and things like that. But yeah, many of these variants are found in only one or two families, so the more data we can get in terms of functional studies and what's going on with these patients, the better.
Okay, I'd like to open up the questions. Do we have any questions? Okay.
Right here. This is kind of a combined question for many of the presenters, so I don't know if you guys want to tackle it or send me elsewhere later. I want to kind of think back into 2018 Symposium, and it was brought to the attention on one of the panels such as this, that most of the pregnancies had been, or all of the pregnancies had been reported as normal and typical, no complications. we spoke in 2018 about my daughter's pregnancy, and then many hands in the room went up and said, not us either, and not us. Has there been any advancements or considerations in extracting that data, compiling that data, looking at that data to get these moms to genetic counselors sooner, to see if maybe we can pick up on early detection and maybe get ahead of the newborn screening in other avenues while we're waiting on FDA approval, such as, or RUSP approvals, like we're waiting on for GAMT?
That's a great question. Personally, I'm not aware of any studies like that. I don't know if any of the clinicians in the audience have been working on anything like that, or if it's some sort of data that could be collected by the registry, perhaps.
Any OBs in the audience?
Is the registry structured to capture this information?
I see Heidi nodding.
Yes.
I can just add one thing that we've seen in New York, that many more parents are aware of not just these types of deficiencies, but a lot of the conditions that we screen for. I think there's definite geographic dependency, so a lot of our families already know they're carriers for any number of conditions that we screen, and that proportion really has increased over the last handful of years. Genetic testing is much more accessible to families, especially in, for example, New York City. So I think that you'll see a change in people knowing. But of course, then you sequence these genes and we don't know what most of it means. So that's still a challenge.
Hi, I have a question for Jenny. So I saw in one of your last slide that in terms of variance classification, for CTD, the number of VUS were lower.
Mm-hmm.
And so I was wondering why is that? Is because it is easier to classify the variants for this gene, or is there any other reasons?
Yeah, that's a great question. One possibility could be if these variants are shown to be de novo, we can apply the de novo codes and that can bump up the classification. It's a great question thinking about perhaps the number of loss of function variants like frameshift and nonsense compared to missense. That's not something I've actually looked at, but it could be that there's more of those types of variants. And those are much easier to classify because we know that those are often resulting in no production of protein. But yeah, that's a great question. It could be a combination of those factors, and also being able to follow, I think, segregation through the families for X-linked disorders. I think typically we see larger pedigrees for X-linked than the autosomal recessive conditions, so that allows the segregation to be at a higher strength. So
Okay,
those
thank
could
you.
be some factors.
Nobody else wants to ask, I'll ask. Just for regards to Clingen and the data repository, it sounds like a lot of that work is really manual, and I'm just wondering have we maybe researched or looked into using any kind of third-party data mining software?
That is a fabulous question. So we do, there are some companies that are working on this. One is called Genomenon or Mastermind, which will help you find scientific articles where the variant is mentioned. So I actually use that one quite frequently. I will say with Clingen, we typically have been trying to use free data sources just so that all the curators have the same, abilities. There is a free version of Mastermind that I use, but there's also a lot more data that's available if you pay a lot of money. So that's one situation. We are also through Clingen trying to develop different data mining technologies and ways to prioritize variants and things like that. So it's definitely on our minds. We do also have a sort of baseline annotation protocol where we have volunteers who are going through papers and annotating the data ahead of time. So while that's not sort of computational as such, it's certainly a resource that's helpful to us. So it's a great question.
I think that brings us to the end of this Q&A session. Thank you so much to all the session speakers and Sarah for moderating this panel.